for all the delegates. Please do give us your input and be free to ask questions. So quickly going on to my talk today, cardiorenal syndrome, exploring the complexities of cardiorenal syndrome. Greetings from Christian Medical College, Vellore, Ranipet campus. We had moved in here in October 2022, and God has been very gracious to bring us this far. The brief outline of today's talk is about a brief introduction, the definitions in cardiorenal. My talk for the next 15 to 20 minutes is to try to take you through the difficult understandings of the cardiorenal syndrome, because it's still a gray area. The dilemmas in the pathophysiology, diagnosis, which is of the use of investigations of biomarkers, and slowly move into transition to the management part, which my good friend Dr. Noble will be speaking upon. So, cardiorenal syndrome is a failure of either heart or the kidney that leads to or accelerates the failure of the organ. It's a kind of a heterogeneous presentation with a heart and kidney dysfunction. And the clinical presentation can be of extremely high morbidity and mortality. Now, the definition, actually the initial old definitions, the two prerequisites were not met. A precise definition that combines cardiac and renal failure, and a mechanistic framework that will facilitate research, that is the mechanistic pathway into what causes the cardiac failure or the renal failure was not found. Hence, the researchers and workers decided to design on a clinical classification on the order in which the organs are affected or the time frame, whether it's an acute or chronic. Now, the key dimensions of the cardiorenal interaction was not addressed. That is, as I said, the primary failing organ. Second, the interaction, whether it's unidirectional or bidirectional. Third, the nature of the disease affecting the organ. And fourth, the pathophysiological mechanisms and time course of development of the interaction was still not known. So from the time period from 2004 to 2013 onwards, we've had various definitions coming up with etiological definitions, clinical definitions, and some of the earlier definitions which was given in 2006 I've just listed. I'm not reading it out, but it was just mentioning about a pathophysiological dysfunction that happens in an individual who comes in failure. Then in 2010, you had another definition of applying all the pathology and the pathogenetic mechanism, which is very difficult to apply in a clinical practice or in a clinical unit. Hence, in 2008, Ronco et al. Brought out this clinical type of definition for cardiorenal syndrome. Cardiorenal syndrome type 1, type 2, type 3, type 4, and type 5. In addition, to have other names based on the time frame of the presentation of the patients that are coming to us, as acute cardiorenal syndrome, chronic cardiorenal syndrome, acute renocardiac syndrome, chronic renocardiac syndrome, and the secondary cardiorenal syndrome. Now, the concerns in this clinical definitions, which is most acceptable, is Ronco's classification, but some of the concerns that were in this definition is to address and define these clinical entities because of the research and the papers that came out, which was difficult and not practiced uniformly and studied. For a simple example, most of the papers, AKI, that is acute kidney injury, was used by nephrologists, whereas this term WRF, that is worsening of renal functions, were predominantly used by cardiologists in most of their studies. The grading of damage to the organ was not done. Biomarkers, as it is difficult to interpret and study and look at its outcome, was not used uniformly in detection of AKI. And the clinical grading of the severity of heart failure was not done. So it was a very complex kind of a situation that the researchers were in to bring in this in. Because of these data that came by 2010, we had the acute dialysis quality initiative classification of CRS. This was based on the primary disease process and looking at the goal-directed therapies. So it was a very descriptive clinical pathological classification, very descriptive. Still does not tell us the mechanistic framework of what is leading to the other, for us to be very clear as clinicians to know what to manage when the patient comes in. Then came the more complex definition. People decided by, again, another 2013, of bringing in all the pathological process. It's very difficult. So These definitions in practice, as of now, it is based on the Ronco's clinical classification that is doing. So the current understanding, it is to take, rather than taking the organ that is affected, take the organ that has initiated the process. The clinical significance of organ involvement versus other organ system at the time of presentation would be of a more of a practical value for management. This dotted line actually signifies the mechanistic framework is still not very clear for us to understand, to classify a clinical syndrome when we have recognized a clinical problem. Because of this classification, the etiological classification is always difficult. There is an interplay between these two factors for us to take into the pathophysiological understanding, which in the two subsequent slides, I'm trying to take you. It's a complex process. Coupling of the heart and kidney, they finally came out, there are various connectors that are in play that is called the cardiorenal connectors, and of which the two main connectors are the hemodynamic connectors and the non-hemodynamic connectors. Very complex, bidirectional, maladaptive, and a lot of crosstalk that is needed. However, there is no hierarchy in terms of its presentation of functional of these two characters, or these two connectors, to say in vivo or in vitro, experimental models or studies to say, look, one dominates over the other. So it is a combination of both. Now the traditional thoughts was the heart failure and renal failure are connected. Both are having an interplay. Basically, there is unable to generate a forward flow. And this difference between the arterial driving pressure and the venous outflow pressure is larger. So there is a decreased blood flow and GFR that happens, resulting in prerenal hypoperfusion, setting off the process, which leads to activation of the renal angiotensin RAS system, leading to fluid retention, increased preload, and increase in renal failure. This goes on to aggravate the heart failure. So basically, a presence of a low flow state only partly explains the pathophysiology of cardiorenal syndrome. Later, some of these registry studies that came up, especially those that were done by the cardiologists because of the terms that were used, the worsening renal function was similar to something like a heart failure with a preserved systolic function versus a worsening renal failure with a reduced systolic function. And they noticed that poor control of blood pressure or elevated blood pressure was one of the factors that was playing a role. The other that they noticed was the role of central venous pressure and intra-abdominal pressure. Heart failure results in volume overload and increased central venous pressure that is can compromise the blood flow to the kidneys, resulting into a low resistance circuit system. The increased CVP in turn causes increased the renal venous hypertension, increasing the renal resistance, aggravating or decreasing the GFR, resulting in a rise in creatinine. And this initial rise in creatinine was always noted because of the beneficial effects of ACE and ARBs that are added into a patient with a cardiac failure. Whether this increase in creatinine was due to the ACE-ARB, coined a term of a pseudo worsening renal function, whereas a true worsening renal function was identified with a reduction in the MAP, which actually exceeds the renal's autoregulatory capacity. Then came the right atrial pressure. Right atrial pressure was the only hemodynamic parameter that in this study that was noticed to study with a baseline renal dysfunction. And a reduced cardiac index was also postulated, it was still not clear. The increase in the intra-abdominal pressure leading to renal dysfunction secondary to renal compression, reduced perfusion, was the other possibility of a hemodynamic factor that was coming. More of all the hemodynamic factors being very theoretical, the researchers noticed that the non-hemodynamic factors, if corrected, which was possible, would lead to a better outcome. And some of these was postulated in the management of cardiorenal syndrome, that is trying to tackle the sympathetic nervous system, the RAS system, which causes the persistent sodium and water retention, the role of the oxidative stress. So the imbalance of the proportion of the reactive oxygen species was leading to the cellular injury, which is causing the fibrosis of the myocardium and distal tubular cells injury. So there is emerging data that there is crosstalk between the cardiac and the kidney dendritic cells. So is there a role of the innate immune systems and the adaptive immune systems is still in role? Again, the role of inflammatory markers, though there are postulates that these inflammatory markers are the ones, especially the TNF-alpha, and one that is very commonly studied is the IL-6, which is contributing to myocardial and renal fibrosis, predicts or have been noted to predict the mortality and the morbidity of chronic cardiac failure and chronic kidney disease and renal failure that is persistently very high when we notice when patients on dialysis as well. What about, we have heard about the CKD-associated toxins. These are two of the drugs that have been postulated to play a role. But the most common that has been identified is anemia, the correction of anemia. We as nephrologists are very, very, very cautious and very apprehensive to really correct the anemia because of the few studies that I have listed below which showed an increased risk of stroke and thrombotic events. Having said that, most of these admissions that of a patient with a chronic cardiorenal syndrome, their admissions were frequent. Anemia was noted to be one of the causative cause for death, and the morbidity was quite high if the anemia was not corrected. So we need to strike a balance to make sure the hemoglobin is well corrected. So stating that too much of overcorrection can affect the outcome of a patient on CKD, but trying to maintain a milieu will keep us at bay for someone with a cardiac failure. So the thought process is, as I said, contributed to frequent hospital admissions and death. And one of the most common things in a practice, which Kedoki has also highlighted, was to correct the iron deficiency. Very limited studies to know correction of the iron studies will benefit the outcome. But we know that correction of the iron studies and iron deficiency will help in the improvement of the anemia. This is again more or less of theoretical of endothelial dysfunction, which is ischemic-induced vasodilation. The fact of the dysregulation of nitric oxide can cause a decrease in the shear stress and pump failure, low blood viscosity due to anemia as the second major contributor. Endothelial cell apoptosis is also noticed when there is a downregulation of nitric oxide. When it comes to atherosclerosis and proteinuria, though there is no causal relationships, studies have shown it's an independent markers for vascular disease. And another that is upcoming is a muscle wasting and cachexia, which actually triggers off the RAS system, has been proven to show independent risk factor for chronic kidney disease and heart failure. Vitamin D is another target of management, which has in correction of vitamin D deficiency, which is known to show a very prominent role because of its regulatory effects on blood pressure and parathyroid hormone. Experimental models on mouses have shown the benefits of cardiac antihypertrophic effect. So from the few slides that the most important which I wanted to drive is the non-hemodynamic factors which can be corrected to give a beneficial outcome, whereas the hemodynamic factors which I do mention helps us in the management to target different pathways of the hemodynamic factors which can benefit us in the therapeutic management. So this pictorial diagram, just try to go with me as it comes. So when we look at type 1 cardiorenal, that is someone with an acute heart failure like a myocardial infarction or someone who has had a heart transplant, this is what actually happened. There is a decreased arterial filling volume. The renal perfusion is reduced. There is a rise in the CVP and IAP. There is also the iatrogenic uses of diuretics, contrast agents. The sympathetic system and the RAS system is activated. This results in the hypoperfusion, reduced GFR, and we develop acute kidney injury in acute cardiorenal type 1. When you look at renocardiac, that is type 3, a patient who presents to you with acute kidney injury, for example, a kidney transplant recipient, or a patient with an acute kidney injury due to drugs, acute interstitial nephritis, what happens to them is that there is a RAS activation, sympathetic activation, there is the electrolyte imbalance, the uremia that sets in. This causes increased preload and afterload, decreased contractility, and the pulmonary vasoconstriction leading to apoptosis and cardiac cell injury leading to an acute heart failure. So when these two systems happens, this process of pathologic mechanism continues to happen till we treat the cause that is related. That is the oxidative stress, the inflammation. All this contributes to an ongoing cycle. When we look at the chronic cardiorenal, that is type 2, someone with a chronic heart failure, someone with a dilated cardiomyopathy, the pathophysiology is again more or less all different. It's of low cardiac output, endothelial dysfunction. You have the neurohormonal abnormalities, again resulting in hyperperfusion, leading to chronic kidney disease. On the other hand, the renal-cardiac syndrome, that is type 4, chronic kidney disease, though the process of RAS and sympathetic nervous system activation is the same when compared to type 1, there is a decreased cardiac function, diastolic dysfunction, apoptosis, chronic heart failure. But the common system is there is an ongoing oxidative inflammation in both these processes that happen. When it comes to the secondary causes of cardiorenal syndrome for someone who comes with sepsis or a septic shock, we all know the dynamics that is involved. We treat the cause and see how we can improve the renal failure and the cardiac failure in the management. So just to summarize, it's a complex process. There's a lot of interplay that happens between the hemodynamic mechanism and the non-hemodynamic mechanism. With that, there is always, when you have such a complex pathophysiology, there is always a dilemma in the diagnosis. Now, when we look at the diagnosis of what to do or how to diagnose, there are some of these old biomarkers, the new biomarkers, and then the imaging. For me, as of today, I still feel the conventional biomarkers, the old is gold. There are limitations in clinical practices, but it definitely helps us in the management. The new novel biomarkers, which is the new silver lining that you can see, what is its role in clinical relevance and its potential therapeutic implications. So what are we to expect reasonably? What do they provide today? And why their performance is still currently suboptimal need to be understood when we try to manage these patients. So it is always good to combine the new and the old and see how we can do it. If you look at the analogy to cardiac biomarkers, it's more or less instructive. The problem for us nephrologists, we still do not have a marker for AKI as sensitive and as specific as troponin. So looking at the cardiac biomarkers, which is actually marked, which I've just highlighted in red, there is no single biomarker that distinguishes all processes of injury, failure, and repair. So we do not have an ideal biomarker, but in a panel of biomarkers predicting the different phases of injury can help us in cardiorenal syndrome for a combination of cardiac and renal. So when you look at renal biomarkers, we have, as we all know, there are plenty, but some of them are the cystatin C, albuminuria. But when it is combined with pro-BNP and cardiac troponin T, there is a prognostic indicator towards a mortality and cardiovascular death. Studies have shown creatinine and cystatin C have different sources in the estimation of GGFR, but significant biases are there. Another important one is to look at the markers of tubular injury. For us, the urine microscopy is always the biological fluid, a liquid biopsy that provides a window into the kidney. It has definitely shown to have a negative predictor for a person who's coming in with an increased risk of a heart failure. Distinguishing functional serum creatinine fluctuations from true AKI is really important. Some of the urine sediments markers that we use are helpful for us in the prognostic evaluation and the prediction of worsening. There are definitely there are markers like NGAL that have been used, or a combination of other kidney tubular injury markers that can potentially tell us the rest. But these are all, when looked in a long-term perspective, very few of them have been singly isolated to say, but definitely a combination has been coming into practice of KIM and interleukin 18. So to correlate, measures of congestion such as BNP or NBNP is very useful. Now these markers of the cardiac are not influenced by the baseline functioning. They are influenced by the baseline functioning of the renal tissues, so they can be inaccurate at the low filtration rate. That's a limitation that we have. To represent a transition to chronicity in renal, looking at biomarkers always will be difficult. So combination of the natriuretic peptides along with the other kidney markers, which are actually, the natriuretic peptides are not dependent on the kidney function, can be useful. And these two markers are still under study. What we have now is a combination of these natriuretic can qualify the worsening of renal functions. So comparable outcomes, intermediate outcomes, and worse outcomes have been noticed with the severity and the rise in the natriuretic So finding supports of a use of multiple biomarkers which can tell us an interaction of play between the two. The imaging modalities is not something new that we do not know that we use, but echo, the renal ultrasound, they're called color Doppler, and the other that can be of use is a speckle echocardiography and MRI, especially in those patients with chronic kidney disease, in which we can look at myocardial fibrosis and structural strain. These are all more or less of an instructive and for research purposes, but these are the other parameters that you accuse, but very limited use in clinicals. The simple reason is because the data is lacking in literature for all the three modalities that have just been noticed to know how much of these can be useful. Hence, the dilemma in management, as I slowly transition to give it to Noble, it's a role of precision medicine that we can use to be very patient-centric or based on how each patient presents to us. You can use a combination of biomarkers, but I will still go with the old markers of trying to do a clinical assessment and how we can successfully do a decongestion process, follow the trends in anemia, see whether there is a worsening of renal function, which can be attributed either to the use of ARB or intrinsic use of diuretics, try to strike a line. See whether we can always use to diagnose chronic kidney disease and, if needed, a renal biopsy. Just one slide to summarize the management dilemma that we all can look, and it's an important gap that needs to be filled. So biomarkers with the ability to give us a glimpse of the current physiology may be the best guide to define the precision medicine. But remember, most commonly in clinical practice, it's type 1 and type 2, which is seen, and the primary driver in these two situations is the cardiac dysfunction. So in type 1 cardiorenal syndrome, this is one scenario that you can face. Increase in serum creatinine with acute heart failure treatment. Try to see whether there is a pseudo worsening renal function or whether it is really a true renal function dysfunction. And based on outcome and position of how the patient makes it out, see whether there is a need to diagnose of a kidney injury and accordingly manage. The other is the chronic situation that you can face. But let's look at whether these blood and urine markers, which is again a combination of both, will be helpful or not, and whether the patient requires a combined organ, heart and kidney transplant or a single organ transplant. It can be only looked at a prospective data. So some of the conclusions in the take-home messages for the definitions, the pathophysiology, bidirectional relationship where dysfunction either worsens the function of the other, practically not possible to specify who actually initiated the event in the current data. Precise clinical characterization and classification of cardiorenal syndrome have not yet been performed. As I said, the pathophysiology is multifactorial, complex, and dynamic, and of which the non-hemodynamic factors of correction of anemia, correction of role of vitamin D should be given importance in the management of these patients. Diagnosis, the old is still the better. Biomarkers still has this questionable role. The medical treatment should actually just focus on improving the cardiac function, reducing the volume overload, and I said need to focus on managing the non-hemodynamic factors. Thank you so much.
Thank you very much, sir, for this insightful and in-depth discussion on cardiorenal syndrome. Due to paucity of time, we'll not be taking any questions after this session. We'll move on directly to the next session. Thank you very much, sir.